Good morning. I am Dr. Rajita Esther. Today I am going to discuss about the MCQs. Mainly I am covering these particular MCQs from autocoids and some from the NS and some from the peripheral nervous system. Let's come to the MCQs. Serine is a nerve gas that is an organophosphate cholinesterase inhibitor. Which agent could be used as an antidote to sarin poisoning? If there is a sarin poisoning, what could be the antidote for this particular poisoning? Is it pilocarpine, carbachol, atropine, or physostigmine? Actually, here the question itself has been given. Sarin is a nerve gas that is an organophosphate cholinesterase inhibitor. So, what organophosphate poisoning? So, what's the answer? Organophosphate poisoning. The answer is C. That is nothing but the atropine. Okay, serine is an organophosphate cholinesterase inhibitor. So, simply organophosphorus poisoning. It causes an increase in acetylcholine levels in tissues that leads to cholinergic crisis through activation of muscarinic and nicotinic receptors. Most symptoms of cholinergic crisis are mainly mediated by the muscarinic receptors, and therefore for serine poisoning, cholinergic agonists such as pilocarpine, carbachol, and the physostigmine, which is also one kind of the indirect agonist, means indirect cholinomimetic drug only. They are also inhibiting the enzyme cholinesterase. So, they are also increasing the acetylcholine levels, physostigmine too. So, all these are worsening the poisoning. So, what will be the answer? It should be anticholinergic. The anticholinergic which was given in the options was atropine. Atropine. So, pilocarpine is the direct inhibitor, carbachol is the direct agonist, pilocarpine is the direct agonist, and physostigmine is the indirectly cholinomimetic drug by inhibiting the cholinesterase, which is an enzyme which actually metabolize this particular acetylcholine. So, when there is no metabolism, that is also causing the increase in the acetylcholine level. As the organophosphorus compounds, these are also irreversible organophosphorus. So, all of them increasing the acetylcholine action. But except one, that is atropine. Atropine is an anticholinergic drug. That's why for this treatment, the answer is the atropine. So let's come to the second question. A patient with asthma was prescribed a beta 2 agonist for acute relief of bronchospasm but did not respond to treatment. Which drug is treatment? Which drug is the most likely next option for this patient? So actually he has been given a beta 2 agonist. Still he need requiring some more other additional drug. So which one you will prefer? Which one among these drugs which can have an additional, can give an additional benefit for the asthmatic patient? Is it benzotropine or ipratropium or oxybutenium or physostigmine? Physostigmine we are already discussed. It's an acetylcholine agonists, acetylcholinomimetic drug. Actually, when you know the symptoms of organophosphorus, so here also what the acetylcholine will do on the smooth muscle, mainly in the bronchus, they will cause the bronchoconstrictor. So physostigmine also bronchoconstrictor. So because it's a cholinomimetic. So acetylcholine agonists, all of them may be directly acting or indirectly acting, they will cause the bronchoconstriction. So physostigmine can be excluded. So benzotropine, ipratropium and oxybutynin. So among these three, which has an action on the bronchial smooth muscle? So major receptor present in the bronchial tissue are muscarinic and adrenergic beta 2 receptor. Muscarinic activation causes the bronchoconstriction and beta 2 receptor activation causes the bronchodilation. Therefore, directly acting or indirectly acting, that is nothing but the physostigmine, muscarinic agonist. So, it will definitely worsen the bronchospasm. So, ipratropium is a muscarinic agonist that can relax the bronchial smooth muscles and relieve bronchospasm in patients who are not responsive, or if they need additional bronchodilation, they can be given ipratropium. Why the benzotropine and oxybutynin, why we are not doing means, actually benzotropine is the centrally acting anticholinergic. It's also an anticholinergic, but it's a centrally acting anticholinergic. So we are using that for the treatment of the Parkinson's disease, like in extrapyramidal symptoms. And oxybutynin is for the bladder overactivity. It will be there, the action mainly on the over the bladder rather than the bronchial smooth muscle. So oxybutynin will be more effective in the overactive bladder than in the bronchial smooth muscle dilatation. So ipratropium is the drug. Option is the B. So ipratropium is a drug which will have a more activity towards the bronchial smooth muscle dilatation. So with addition to the beta 2 agonists, we can go for the ipratropium bromide. It's an anticholinergic drug. And also next, which is the most effective anti-motion sickness drug for a person planning to go on cruise? Anti-motion sickness drug. Options are atropine, fesotorodine, scopolamine, tropicamide. So here also, these are all also anticholinergic drugs only. In the previous questions, those are the most of the three options are also anticholinergics. Here also, these are all the anticholinergic mostly. So which one we have to choose for the motion sickness? All muscarinic antagonists like anticholinergic drugs listed above are theoretically useful for anti-motion sickness. However, scopolamine is the most effective in preventing the motion sickness. Tropicamide we are using mostly for the ophthalmic uses. Fesoterodine is used for the overactive bladder. Okay. So, we are using mainly scopolamine for this particular condition. All are anticholinergics, but which one is the effective means scopolamine will have a most effectiveness over that. Fourth question. An ICU patient with severe lung injury requires a neuromuscular blocking agent to assist in his ventilator management. He has liver disease and is currently in renal failure. Which neuromuscular blocker is the best choice for this patient? Citalopram, pancuronium, vicuronium and rocuronium. All are the oniums only. Means all are the skeletal muscle relaxants. All are NM receptor blocker. All are non-depolarizing skeletal muscle relaxants. So among these, which one we have to go for? With the patient who has already have a renal failure and also liver disease. Pancuronium is renally eliminated and the patient has renal failure. Vicronium and rocuronium are hepatically metabolized and the patient has liver disease. Cisatracurium. Cisatracurium is cleared by organ independent metabolism, that is called the Hoffman elimination. So we can go with this particular drug which is eliminated through the Hoffman elimination. So the answer is Cisatracurium. The answer is the option A. Pancuronium cannot be because it eliminated through liver, renal. Vicronium and rocuronium both are metabolized through the liver. So Cisatracurium is the answer. Good option for this particular question. Where would you expect to see the first return of function in skeletal muscles following discontinuation of a non-depolarizing neuromuscular blocking agent? Where we would expect see the first return? Is it arms or diaphragm or fingers or pupils? Which one first? Following administration of the neuromuscular blocker, the facial muscles are impacted first. But the pupils are not controlled by skeletal muscles and are not affected because the pupils, the surrounded muscle was the smooth muscle. Iris which made up of the circular and the radial muscle fibers of the smooth muscles. The fingers and arms would be next with the diaphragm function last. Function returns in the opposite order. So function of the diaphragm returns first. So here when you go with the clear the question, where would you expect to see the first return of the function in skeletal muscles following discontinuation of the non-depolarizing neuromuscular blocking agents? Actually, it is the drug has been given and the drug has been discontinued. Then where first you will see the response after discontinuation? If the question, that is why we have to go with the clearly we should read the question. If the first return is it's a first return. If we are asking for the question first, when we have given the drug, where is the losing of the skeletal muscle causes the skeletal muscle relaxation will be the facial muscle. When the drug has been given, the immediate response we will see in the facial muscles. Okay, next in the fingers, next in the diaphragm. People doesn't have any role at all. People with made up the muscle which made up of as the smooth muscle. So there is no role of the skeletal muscle. So arms, diaphragm and the fingers. First arms, next ikkada fingers, next diaphragm. But here the question is returning. Returning of the action means the answer will be the diaphragm. So diaphragm, once we are discontinued, then the first returning of the function will be the diaphragm. That is what this particular slide is saying. Following administration of the neuromuscular blocker, the facial muscles are impacted first. But the pupil has no control because it's made up of smooth muscle. In fingers and arms would be the next. With the diaphragm will be the last. But here returning of the function will be the opposite. Diaphragm will be the first, next arms and the fingers will be the next will be the facial muscle. So answer is B, that is diaphragm. So what which statement? Okay, till now we have mainly discussed about the peripheral nervous system lo mainga skeletal muscle, some of the anticholinergic drugs. So we will continue with the next video about the remaining slides in this particular PPT. Okay, thank you.